Rawaf, for having us. Today, we will be discussing a new vaccine and the COVID-19 pandemic. And only today morning, headlines over the whole world were about our topic today. German tech vaccine judges for using next. That is a great news and bring for the whole world. The update of the November 12th analysis for the candidate vaccine COVID-19 vaccines revealed that 212 vaccines and 8 at phase 3 trial, 3 vaccines at its stage, and one of them had been just approved by agency, which is the RNA technology platform used. Administrative will be through the from phase 3 the serious adverse events, neurological illness, and there are 5 countries from Arab world participating in the clinical trial, which are Egypt, United Arab Emirates, Morocco, Bahrain, and Jordan. Despite the great news of today, this is not of what is going on. There are many challenges like longevity of response, the safety at long term, need more in-depth analysis and researches. Also, there has been a trade-off between the WHO SAGE value framework, allocation and prioritization of the COVID-19 vaccination and the context of limited supplies. So we do have many areas to cover, and we have two distinguished speakers. It's my privilege to introduce the first speaker, Dr. Hasan, from WHO Regional Office for Eastern Mediterranean, the Vaccine, Preventable Disease and Immunization Department. Dr. Hasan will cover the current situation of vaccine race and the fight frontrunners, WHO views on how to fit the COVAX secure allocation of tuition, 3% for the health workers and 17% for elderly above 65 years old, and the role of UNICEF and other partners like Gavi Alliance in this important partnership. Dr. Hasan, the floor is yours.
It seems that Dr. Hasan, Chairman, maybe Dr. Omar should start until Dr. Hasan will be with us.
Sure,
Dr. Omar?
No problem. Sara, do you like to do introduction?
Okay, so sorry. Yes, sure. So I'm sorry for the technical issues. We will start with our other distinguished speaker, Dr. Najim, the Senior Advisor in the United Arab Emirates Ministry of Health and Prevention. Dr. Najim will be talking about the logistic, the clinical views, the possible long-term impact on using or non-using the vaccine. So Dr. Najim, the floor is yours.
Thank you very much, Dr. Sara. If you can give me 1 minute just to share my screen.
Sure.
Can you see my screen now? Excellent.
Yes.
Good morning, good afternoon, good evening, everybody. Thank you very much, Prof. Rawaf, Professor Khoja, and Sara for giving me the opportunity to go through what is going to be, the challenge that most of us know about the vaccine is huge in developing it. It's the first time in history that we have a vaccine within 10 months from start to passing and even getting an emergency approval, which we should note around this. It's an emergency approval. But there's an equal challenge that many of us already started hearing about. We've been working on it for the last 6 months in an equal measure, apart from securing the vaccine for the population that we are serving, was working out the logistics. The logistics is going to be no shorter challenge, no smaller challenge than developing the vaccine itself. In a sense, what we're going to face over the course of the next 2 years is the largest airlift in the history of humankind. So the more that countries, populations, NGOs, pharmaceuticals, as well as logistical companies prepare for, the more likely that the immunizations program that will follow and get implemented at local, regional, or national level in different countries will be more successful. So what do we know about the vaccine themselves? We know from a logistical point of view, governments or entities that are responsible or worried about the vaccine will face a hard challenge for vaccines in terms of logistics. There are 8 different technologies. So everybody knows about the Pfizer one, which is an mRNA technology platform. There's also the AstraZeneca one and the Russian one. Both of them are viral vector. In that category, also you have Janssen vaccine, which Johnson & Johnson is developing, also viral vector. The third one is the attenuated dead, which is most of the Chinese vaccines, so Sinovac, Sinopharm, the Indian vaccine that is under development, as well as a couple of other vaccines that not many people know about. And then last but not least is what we call the protein subunit vaccine. So protein subunit, you might have heard about Novavax, who's already started phase 3 trials in the UK, and they are planning on starting their phase 3 trials in the US. Also, the Sanofi-GSK collaboration, also going to be a protein subunits. Now, within each of them, there will be different vaccines. So you've got Actaurus from Singapore, you've got Imperial College. Both of them are mRNA, but the Imperial College one is more of a recombinant mRNA, so it's self-replicating. 8 different technologies, so you look at it in different ways. Now, we anticipate that about 20 to 30% of the shipments of all the vaccines going to be produced next year, and there is a commitment from various entities overlapping with COVAX commitment as well, to produce north of 6 billion doses. That's almost enough for 3 billion people, apart from the Johnson vaccine, which is going to be single dose. But 20 to 30% of the shipments will likely to require -20 to -80, which is 80, and that's the Pfizer vaccine we're talking about. So the likes of Moderna, Pfizer, BioNTech collaborations, Imperial one, Actaurus one. Otherwise, it's mostly going to be similar to the experience that we already have around transporting vaccines of 2 to 8 degrees Celsius, albeit that the quantity is going to be much bigger. Shipping cost, we're anticipating the -80, or what we call the frozen chain or the ultra cold chain, is going to be about 6 times higher in prices to what we currently used to for the cold chain. Logistic solutions now, this is the problem. So logistic solutions are not only scarce because everybody around the country, every entity will want these vaccines as fast as possible. So the time scale is going to be very short. All of the companies are coming towards kind of finishing their vaccine at the same time, almost. So we already have in hand almost 4 of the vaccines, counting the Chinese. The Chinese already have 3 vaccines in use, by the way. And you've got the Pfizer, the Moderna, and the AstraZeneca now. But many of the, about another 6 vaccines will be coming off the line in terms of clinical trials in Q1. And that means 2021 is going to be a massive production of vaccine that need to be transported to different places. So there will be a scarcity of resources around lifting. But also, we're talking about something that haven't been used before. So the -80, the technology before, although there's been some solutions being is going to be trialed now, hasn't existed before. Added to that, the main production facilities, as we all know, so 80% of the vaccine is being produced in North America and Europe. Surprise, surprise, 80% or probably north of 80% of the world lives outside North America and Europe. So again, it's going to be an operation spanning the whole world. Now, what the vaccine solutions you need to put in place, and this is what Abu Dhabi did and for the UAE, is basically, it's thinking about it to be more than just transport. It's demand planning, sourcing, training, digital and technology infrastructure that need to be in place. The time variance need to be very minimized. There's no point in having a transportation cold chain that will last about 3 months from getting it off the factory to the shoulder of the individuals that is going to be vaccinated. As much as possible, make it a direct to customer approach, appreciating you might need a regional hub and spoke, removing the middle steps that, for example, you might be manufacturing in Russia or manufacturing in Basel in Europe, and suddenly you say, I'm going to use single airline, flying from Munich, getting down to Austria, then traveling all the way to Egypt, and from Egypt traveling to a Democratic Republic of Congo in order to get to Rwanda. So that doesn't work. You need a centralized hub that will have connection with all of these places in order to get it there. Zero experience. So the training is very important because there is zero experience from from airport handlers, from airport themselves, from customs, from people in clinics in countries of -80 degrees Celsius. Novel packaging will be needed. Of course, there are solutions coming through. SkyCell is one. Pfizer themselves will have a novel packaging around their vaccine, albeit that novel packaging will have limitations around how many can you put in an airplane. And vaccine supply for significant parts of the global population might not be possible. It's all well and good that we have a vaccine, we have production line already churning these vaccines, but bear in mind, not everybody will get it. And I think it falls on the audience of this call today to understand how to manage that, how to manage their population expectation they are serving, how to manage, how to make it in an orderly way, and to gain the maximum benefits of any immunization program they put in place. We feel that after formalization, stabilization, so bear in mind that the Pfizer vaccine, Moderna vaccine will come in a 5-dose vial that you need to add normal saline to it, and will make 5 doses. Once that happens, where you're adding normal saline, then you are reverting back to the normal fridge temperature, which is 2 to 8. But bear in mind, the Pfizer one will only have 5 days. So it's use it or lose it. Moderna one will have a longer time for that element. Many of the AstraZeneca vaccine, for example, will come in 10 doses vial. So again, it will be used on that terms. Okay. So if I may go vaccine and cold challenges, you know about these challenges. Regulatory approval, Pfizer passed the first hurdle in the MHRA. There is still the EU and the Americans also to approve it. And of course, being approved in localized area. If they pass the MHRA, this carries a great weight, obviously. The product release and the quality assurance, I do advise everybody, every country responsible for purchasing these, or even with either directly on bilateral agreement or through COVAX agreement, is to check what would the quality assurance. There is an element because of the vaccine, and you have to appreciate that because of the vaccine has been done within 10 months, most of the contracts that you will be looking at, if you are involved in looking at these contracts, will be pushing for indemnity clauses, basically. So they will be telling you this vaccine has been rushed. We usually take about at least 2 to 3 years post-marketing trials in order to be responsible for it. But as you appreciate, the weight is high. And this is where the weighting between the pros and cons of doing this that you need to put in place. Supply shortage, we alluded to that earlier. High volume production, of course, it will be there. But there are, for each of the vaccines we're talking about now, there are 5 to 6 manufacturing plants around the world. They are not necessarily belong to the company that is going to be selling you the vaccine. So, for example, Moderna is going to manufacture much of them in Lorenza in Switzerland. It's a contract manufacturing place. Same thing with AstraZeneca. So you have to take into account where is that coming from. Of course, I mean, there is the area of tech transfer, and the assurance has been done by the company, but an added part need to be on you. Physical damage, we know from experience that from dealing with many of these vaccines, the lower the quality of the supply chain handling and supply chain availability of cold or ultra-cold in the country, the more likely there will be physical damage. This physical damage could be between 10% in the best of scenarios all the way to 40% of your shipment in the worst of scenarios. Temperature controlled transportation need to be monitored. Of course, the more reliance on pen and paper, the less likely you will have assurance that the temperature integrity has been maintained all the way through the supply chain. Inventory storage, where would you store it? Security and theft. Security and theft is a big thing, by the way. We might see it as this is a vaccine, it's a fantastic invention of and a proof of the ingenuity of human beings, but do not underestimate the security and theft. These vaccines will pass many points where they are what we call blind spots. And you need the assurance, whoever is the company that's going to be transporting this, is they have tracking, they have assurance. You don't want a box to be replaced, let alone taken away. So if it is taken away, you at least can factor into that and say, I'm supposed to receive 10 boxes, I've received only 9. But I wouldn't be surprised, and definitely that's the chatter we're hearing, that organized crime are on the move. Vaccine is a very high value from healthcare and from other elements, and that include everywhere. And the final dose, the final mile dose side. Now, what do you need in order to carry a vaccine? You need cooling systems, you need cold storage, you need cold transport, and cold processing and distribution. All of this need to be in place. In Abu Dhabi, we were fortunate enough that we've been working on this for the last 10 months. The world been working on vaccine development, and we thought we want to develop something for the whole region. So we got SkyCell, which is the most innovative cold containers company in Switzerland, to co-locate to Abu Dhabi, and now they have a regional center and manufacturing. We have Abu Dhabi Ports, which has the largest frozen and cold storage facility in the whole region, 3 times combined. So we mapped the whole facility of cold storage across the region. Abu Dhabi have the highest. Unfortunately, the rest of the region is not very well prepared. And we procured the technology to store up down to 86 degrees Celsius. Now, Etihad Cargo, working with the IATA, they got the first certifications on pharma safe airline and the cold processing. And then we're combining this with technology and quality assurance. What's the capacity needed? It's a huge capacity, needless to say. 2 to 8 degrees is going to be the biggest, but everybody seems to be concerned more about the -20 and -80. Appreciating that -20 and -80 is a very big thing, and it should occupy part of our NAN, but do not forget there are about 80% of the vaccines are 2 to 8. So it might be just a matter of a few weeks waiting for AstraZeneca, Janssen, the Chinese or the Russian, or some of the American ones that might come through development line, and I'm sure 2 or 3 or many more of them will be very much assured, especially they are based on technologies that are not 100% new. There will be 8,000 cargo planes needed if you're only going to load these cargo planes. If you load these cargo planes with only frozen, you need to multiply that by about 4 times, because with frozen vaccines, so the -20, -80, you need dry ice. With dry ice comes the catchphrase of dangerous goods. Airplanes do not transport more than 1,000 kilograms of dry ice. They are considered as dangerous goods. Hence, the maximum they can transport possibly is 250,000 or 500,000 of doses, depending on the technology used. We worked with SkySal on increasing that by 3 times now. And the airport nerdiness, as we were saying earlier, you need training for customs, and you need training for handlers in order to get this. You know this slide, which is basically the various points where you always think about, which is basically the transits, the airplanes, the storage, all the way to the inoculation center where it's going to happen. This is the frozen chain and what you can do about it. Some of the elements to think about on tracking the whole thing, as well as tracking your patients. Many of these are 2 doses, and as you appreciate, 2 doses carries even more headache by itself, because what you're going to have is some people will come for 1 dose, and there will be a huge dropout or a misunderstanding that if you get 1 dose, you get half of the immunity. It's wrong, of course. If you get 1 dose, that means that you are not getting anything unless you get the second booster dose to get the immunity to the level that you want. And you've got connections in terms of IT that need to be between the consumers, the providers, the clinics, the venue, and all of that. And bear in mind, you are serving multiple stakeholders. So you need to think about the safety for the consumers, the scaled service support for pharma, tracking vaccine receipts for the government, appreciating that the government is going to be paying for it, monitoring adverse events for regulators, appreciating this is the first time some of these vaccines being used as a technology. It hasn't been used at all in cancer or in anything else. So this is the first time they are being used. And of course, research data for academia in order to make sure that the whole world, let alone the local entity, is making absolute benefit of what's going to happen. I'm going to say, I'm sure, so the worrisome need to be always, despite the advance of technology, despite of the advance of regulation, we are in a place where nobody has ever been before. And nobody in this generation can claim, yeah, I've been in this place before, I've seen it before, we should do it this way. Collaboration is key, listening to each other is key, and understanding what makes us fear and what made the public fear is key. And I think this should be the way forward. Thank you.
Thank you very much, Dr. Najim, for the very informative and valuable talk. And I'm not sure that we have Dr. Hasan yet online.
Hasan with us, yes.
I'm back.
Yes, okay. Hi, Dr. Hasan.
Hi, sorry, I was stopped.
And
thank you.
It's okay. I would like to introduce Dr. Hasan from WHO Regional Office, EMRO Office, the Vaccine and Preventive Disease Immunization Department. Dr. Hasan will cover the perspective of the WHO of the current situation of the vaccine, the 5 front runner, WHO view on how to this fit with COVAX, secure allocation of 20% of the population, and the role of the other partner, UNICEF, Gavi, and other partners. So
Let's start.
yes, please.
Hi, good evening, everybody. Again, as I was introduced, my name is Quamrul Hasan. I work in Vaccine Preventable Disease and Immunization Unit in Eastern Mediterranean Regional Office of WHO. So I'll talk about COVID vaccine. Of course, that's the subject for today. That's the outline of my presentation. First, I will talk about COVAX facility, and then the COVID-19 vaccine landscape, allocation and prioritization, and country readiness. You all heard about COVAX facility, and you know, many of you, about COVAX facility. That's an arrangement made by the partners, and WHO is part of that, to ensure fair and equitable allocation of, which is not an easy job. And I'll tell you soon why it's not easy job. This COVAX facility is for everybody. It's not a certain group of countries. It's however, among them, 92 countries which are overseas development assistance supported, we call them AMC 92, this group of countries. They are part of it, which are comprising mostly low income and low middle income countries. This AMC is an instrument for to support these OD assisted countries. AMC stands for Advanced Market Commitment. That's a mechanism Gavi used this for long. Gavi is the Vaccine Alliance to support certain eligible countries. So the same instrument is used to support these 92 countries. In short, we call AMC 92. That's the landscape of COVAX research and development portfolio. There are 9 assets, 8 in the human trial stage, and you can see on the top the candidate's name. And many of these are familiar. Now everybody knows this. Everybody reads these names every day in newspapers and other medias, Moderna, AstraZeneca, and so on. Their location and their current phase. All these are in advanced phase, except last 2 in phase 1. And here is another one marked as that's phase 1. These 9 vaccines are in the COVAX facility portfolio. But there are more under discussion, including the famous Pfizer and a few others, which you are expecting to be included in the portfolio soon. But at this moment, these are the 9. This is overall landscape of 47 candidates that those are in human trials and different stages. On the left-hand side, you see a different technology platform that are this indicated. And then different phases, phase 1, 2, and 3. Of course, the last column is our interest, phase 2B and 3, and all these known names are here. You can see few names are marked with border with orange color or purple color. These are the legends. This orange color border are COVAX MOU or SY signed. These purple dots are CEPI agreement signed. CEPI is one of the partner of this of the COVAX facility, and these other legends are up there. This is the process of how a country can get vaccine from COVAX whole pathway. The first step is confirmation of participation, and then the preparation, readiness, where we are expecting that first vaccine is approved for use. The news that's today the Pfizer is approved, UK, or the regulatory authority. Then comes readiness assessment, then allocation, vaccine release, and delivery. That's the whole path. We are right now here in the preparation phase. Overall, till to date, 189 participants, participating countries or economies joined COVAX facility, which comprises over 90% of the world's population. Those 97 are full financing countries, and 92 are AMC 92 countries. Now you may ask, this question may come, what about in our region? In our Eastern Mediterranean region, there are 22 countries. 11 countries are self-financing, and which you can see in blue color, and 11 countries are AMC supported countries. Out of these 11 AMC supported countries, 7 are Gavi eligible, and 4 they are a newcomer who were never Gavi eligible, but now they are AMC supported countries. Those 4 are Morocco, Tunisia, Egypt, and Palestine. And other AMC supported countries you can see in the map: Sudan, Djibouti, Somalia, Yemen, Syria, Afghanistan, and Pakistan. The remaining 11 are self-financed countries. Now, in our region, all these 22 countries, they are participating in COVAX. These are the most advanced candidates, the phase 3 clinical trial. But I acknowledge that things are changing so fast. A few things maybe already moved further than what is written here. First line, the Pfizer is now already approved by UK regulatory authority, you know. These are the front runner, you can say, the Pfizer, the Moderna, Invest, Oxford, Cancino, etc., etc. So these are the final stage, and we're expecting them, many of them, to publish their clinical trial data, phase 3 clinical trial data soon. They will submit for regulatory approval to different regulatory authority, including WHO, soon, and the vaccine will be available in the coming few months of next year. Now, who has the vaccine? Okay, we have some front runner, that's a good thing, but access is another challenge. This slide is taken from UNICEF Supply Division dashboard. Who are getting this vaccine? Now, you know, many rich countries, developed countries, they have their bilateral agreements. Many of them, they procured the secured vaccine more than the need of their whole population. And you can see the first line, the United States, these are the figures, 2.6 billion doses they secured, and so on the other countries. So many of these countries, I'll show you the next slide, how excess vaccine they secured, and that can put risk of these low-income countries or low middle-income countries who cannot afford to buy directly from the manufacturer. This is another slide I took from Nature. You can see the first row, the Canada, they procured almost 9 doses each of their population, or each of their citizens, and other countries as well. This is so high volume of vaccine they already secured, more than they need. Now, how many doses will be available by when? We have vaccine, and there's a good news, and these are coming, and so preliminary result is showing good efficacy. We hope many of them will be approved soon, but production capacity is a challenge. And this slide shows production capacity of this year and coming years. This first bar is 2020, second bar is 2021, first half, and the next one is second half, 2022-23. So it's not enough to have a successful vaccine. Also produce enough capacity, have enough capacity to produce sufficient dose for all target population. That's another challenge. This slide shows the price range of different vaccine as available so far from different sources in the UNICEF Supply Division dashboard. And you can see these are as low as $3 per dose and as high as $44 per dose. So it's a huge range depending on the technology they are used and of course their manufacturer and other criteria. But these prices are not fixed for all candidates, all clients. For different clients, the same manufacturer, they are using different price. Now I'll just talk about the allocation framework, how this allocation are planned. from the COVAX perspective, COVAX facility perspective. COVAX facility, the main objective is, the goal is to protect the public health and minimize societal and economical impact by reducing COVID-19. To attain that goal, the phase 1 will target those people who are at most risk and the most important to maintain, protect the health system and minimize the societal and economic impact. And that's how you can see here, the first 3%, you consider the health and social care workers. All countries received enough dose, that is almost 3% on average, that global average in tranches, so they can protect this group. And then another 17% for high-risk adults, that's elderly, adult with comorbidity, and other having different risk factors. So this 20% of the population is aimed at phase 1. And then on top of that, following doses when it comes available, they reach other target groups. And beside that, a buffer will be set aside for humanitarian deployment, unfortunately, many people in our region as well, who are displaced, refugee, or are under no government responsibility. So those kind of humanitarian situation, there will be a buffer will be set aside. I'm talking about here the sales policy development and steps and process. There are 3 steps. The first one, the sales value framework, which was published on 14 September. Tells us about the principles and objective and target group for COVID prioritization, values based on which these are set. Following that, the next month, that is 20th October, the roadmap for prioritization was recommended by SAGE in the context of limited availability of vaccine. And the third one will come when a particular vaccine will become available. Like now, Pfizer vaccine it's approved. So SAGE will consider what the recommendation specific for Pfizer based on its characteristics, its safety data, its efficacy data, and all these things. So this third policy recommendation will come specific for every vaccine as and when those become available and approved for use. This value framework, which is based on 6 core principles and 12 objectives. Principles are human well-being, global equity, reciprocity, equal respect, national equity, and legitimacy. This document is available in this link. And the roadmap for prioritization, which came on 20th October, that considers three dimensions. One is epidemiologic scenario of COVID-19 disease in the country or in an area, public health strategy the country like to focus on, and vaccine supply scenario. Based on these different recommendations are made. But these recommendations are made taking into account few assumptions. So these recommendations are not concrete. If these assumptions change when we have more information for any vaccine or every vaccine, those recommendations will be adjusted accordingly. Now, this is in summary how these recommendations are put in place. There are 3 scenarios, epidemiologic scenario, as I said. One is community transmission is ongoing, which is the case for all of our country at this moment. Then sporadic or cases or cluster of cases, and finally no cases, which we desire to have someday. For each of these different epidemiologic scenario, there are different public health strategy, and these are the described bottom here. Since we are now at community transmission stage, I will just talk about this first one. The initial focus is reduction of morbidity and mortality, and maintaining most critical essential service and reciprocity, which may further expand to reduction of transmission to further reduce disruption of social and economic functions. And similarly, in other epidemiological situation, different public health objective strategies would be adopted. How the supply will happen? We know supply limitation is an issue because production capacity is an issue. So at the earliest stage, we expect very little supply, very limited supply, which we can stage 1, that is 1 to 10%, but even not 1 to 10% will come at a time. It will come at phases in fragmented. And then stage 2, when limited availability, 11 to 20%, and stage 3, the moderate availability, 21 to 50%. And then it's become further. Now, this is an example of community transmission scenario. Stage recommends whom to prioritize. In stage 1, when the supply will be very limited, less than 10%, the first stage, like even 3% supply, health workers and other social workers at high or very high risk, they should be prioritized. And then comes the other risk group like older adults and defined by age-based risk specific to country. And so on comes in the second stage when more vaccine become available, and the third stage when more production capacity can provide us further vaccine. One of the important considerations says recommend that national equity consideration to ensure vaccine prioritization within countries take into account the vulnerabilities, risks, and needs of groups who, because of underlying societal, ethnic, racial, geographic, and biomedical factors, are at risk of experiencing greater burdens from COVID-19 pandemic. That's quite important for every country to consider when they set their own priority, when they identify their own priority target group. It tells about some highlights of recommendation of WHO EMRO Regional Immunization Technical Advisory Group meeting that happened on 16 November. This regional technical advisory group, they supports the SAGE value framework and roadmap for prioritization. And this technical advisory group also took note of COVID-19 epidemiology in the region, high number of refugees, displaced and marginalized population in our region, and encourage countries to use SAGE framework and roadmap and suggest to adapt this according to their own COVID-19 epidemiology in their country and consider refugee and marginalized group. These recommendations are still not officially final, but these are the main basic message came from ArPHA, and that's why I'm sharing here. Now I'll talk briefly about country readiness. Before going to country readiness, I explained how COVAX facility will provide the vaccine. Now, the self-financing countries, they will receive the vaccine according to their desire. They committed during their participation confirmation. Different countries, they requested for different amount of vaccine for different percentages of their population, 10%, 20%, or other figures. AMC supported countries, they are also going to make a request which will be submitted by 7 December, that is next Monday. And some portion of their vaccine allocation will be fully supported by donors. Gavi is aiming to provide this support for up to 20% of the population for all AMC countries, but this is subject to availability of resources. But we are aspiring that at least 20% population on this AMC supported country will get the vaccine without any cost. But these countries, they can request for additional vaccine, but for that they have to pay their full cost. Like if a country decides to request for 30% population vaccine, 20% they will get from the donor subsidy. Remaining 10%, they'll have to pay the cost. That's its cost sharing. So that's how it happened. But for that, they have to follow some terms and conditions, which they will submit along with the vaccine request in 7 December. Now, to prepare for the countries, what we are doing and what are the suggestions for the countries to get ready. WHO has published a national deployment of vaccination deployment and vaccination plan guidance on 16 November. This is built on core principles of WHO SAGE value framework and prioritization roadmap and fair allocation mechanism. This guidance also based on some key assumptions, the best available information at that time. But it's an interim guidance. Definitely when we will have more information, this guidance will also be updated accordingly. This is published by WHO, but this is a joint effort between many partners, including CDC, CEPI, Gavi, and others. This guidance will be available in this link. It's available here in the slide. There are different sections of the guidance which will help the country in their preparation for the deployment of this COVID vaccine when it become available. WHO also developed a tool for COVID vaccine introduction readiness assessment that to be used by every country. We have circulated this tool to our country offices and desk offices to all the Ministry of Health in our region. They can use this tool to assess and monitor their own progress in readiness, and indeed they can seek support. Also, they can improve their challenges, overcome their challenges. Few critical steps we urge all countries to focus on for readiness: establishment of a national technical working group, which many countries, most of the countries did in different name, not necessarily has the same name, but a technical working group. This preparedness and readiness assessment to be done, that's important. This tool helps in finding out the gaps and bottlenecks. The plan to be developed, which encompasses all the nitty-gritty for successful rolling out the vaccine. Indemnification, liabilities and regulatory system, those to be reviewed and complete the indemnification liability documents as provided by COVAX facility. Healthcare workers and other target groups to prioritize, and multilateral development bank financing to seek for who need, which country, those countries who need assistance. What we are providing from our regional level, a regional working group established. We call RW Regional Working Group for COVAX. Here, not only WHO, the other partners like UNICEF, Gavi, MFNet, US CDC, IOM, World Bank, IFRC, African CDC, and etc., and other CSOs, they are part of this regional working group. We have 6 subgroups. So far, we have arranged multiple webinars. On the right-hand side, you can see different webinars we arranged so far for different groups of countries or different stakeholders in the countries. And we have also planned to do a few more in coming months and weeks and months. Besides that, we also share different guidelines and tools as when unavailable. And we are also supporting the countries so individually one-to-one basis or different group as a group according to their need. Thank you. That was all from my side.
Thank you, Dr. Hassan, very much for the important and rich presentation. Now we would like to invite panelists, Prof. Rawaf, Prof. Khoja, and Dr. Rahim. The panel, the floor is yours.
Well, thank you, Dr. Sara. Thank you very much indeed. And thank you, Dr. Omar, and thank you, Dr. Hassan. Actually, very enlightening. Although listening to you carefully and taking some snaps and notes, you make us feel, that there are so much work need to be done. The good news, not necessarily good. It's lovely to have the vaccine, but the logic of receiving that vaccine may be a nightmare. Let me welcome my colleagues on the panel. Let me start with our guest, Dr. Ali Rahim. Dr. Ali Rahim is a consultant physician and cardiologist from Basra University Hospital and Basra University Medical School, and of course the Vice President of the Arab Public Association, my good friend and colleague, and fantastic man, Professor Tawfik Khoja. Welcome. Great to have you all with us. I think you raised in this fantastic, excellent presentation, actually many questions, not only for the panel, but for also the audience, because we already received questions from colleagues, which I will share it with you. But let us take the clinical experience, and I want to listen to Dr. Ali, the clinical experience. As we know, in China already people are vaccinated, and whether this vaccine, the Chinese one, is protecting the people or not. Dr. Ali, to you.
Okay. Thank you, Professor Rawaf. Thank you for asking me to share idea and experience. Assalamu alaikum jami'an. COVID-19 actually is a unique, it's unpredictable behavior. And actually there is no guarantee immune post-infection. And probably whether there is long immunity post-vaccine, we don't know. Mid-time, the time factor is important for the safety and for efficacy of the vaccination. Actually, I would like to present a case study in the last 2 weeks. Is a young Chinese man. He's working in oil company in Basra, south of Iraq. Actually brought to the outpatient because of loss of consciousness. He was comatose. And actually he was in metabolic acidosis and in hyperglycemic ketosis. So was in acute ketoacidosis. And there is no history of diabetes before. With low-grade fever. In the history, and the history is not easy from the Chinese man. So the translator, it's difficult sometimes. Anyhow, he had received 2 doses of Chinese vaccine. What type of vaccine, we don't know, but it's 2 doses of the Chinese vaccine. The last dose was in September. More information, there is some security from the Chinese companions. Anyhow, treated as such, and actually PCR taken, and PCR was positive. To start, the panel of investigations, and the same is the metabolic acidosis, and there is evidence of renal and pancreatic injury as well. There is increase in the urea and the creatinine. There is increase in the amylase, increase in the lipase, in addition to his presentation of acute diabetes. To start, was not desaturated. The oxygen saturation above 94. But later, days after, probably 2 or 3 days after, oxygen down. And so we revised his CT scan, which was normal 5 days before. And I will share the CT scan. CT scan strongly positive of the viral and suggestive of COVID. And of course, PCR positive. Treated as such with our protocol used to the antivirus, antibiotic, anticoagulant, dexamethasone, all the, unfortunately, he is responding. He is responding very well in the short time and oxygen independent, and the start to conscious level, definitely he is becoming oriented, and all the clinical indices improve. And we did for him as well the serological test, rapid test. So was IgM just detected. There is no detected IgG, just IgM. So COVID and severe COVID, and affect the respiratory pneumonia and the the kidney, the pancreas, it's all the systemic manifestation. But he is fortunate man, he is improving. And the 2 days before discharge his office, and he's getting quite better. This is the scenario of this patients and this Chinese. So that's definitely there is no immunity. It is.
That's very interesting.
Sorry?
Rahim. I said that's very interesting.
Yeah. Yes.
Some of the Arab countries, they do have the experience of the Chinese vaccine. Again, we don't know which one. We may ask Dr. Najim later on. But I mean, let us see this good news and how you want to share with us this. Yeah, carry on. So you want to show us the significant things in the lung?
Yes, with PCR positive, with all other indices of the, clinical, radiological, molecular, all these are straightforward the case of COVID-19 and severe COVID-19. That means there is no any protection, or sometimes even the question sometimes raised, if a failure of vaccine, what's the result? Is the result just simple infection or severe infection or more than severe?
This is a good question, Dr. Rahim. Thank you very much. Let me take this a little bit further. We have a question from Dr. Muhammad Al-Khatib, and he is a family physician. He's saying, how can we manage the public trust on vaccine efficacy and safety? He said most of the people, I think this is his understanding, most of the world population still has a lot of uncertainty regarding the safety. Dr. Hasan, are you sure about the safety? Are WHO sure about the safety?
Thank you. That's a tough question to give such guarantee. Huh? But I can tell you what will be the procedure. Yes, this is a unique situation. Now, there are huge demand for this vaccine because of the fear of the pandemic. At the same time, there's a huge concern about the safety of the vaccine. Because
so how we balance between these two?
Yeah, because of this, record-breaking time, it's becoming available. So many people, they raise questions about these issues. And yes, we as a public health professionals, we have to balance based on the evidence and data. Now, it's true that this development process, the whole world put their all resource. So all scientists, all the big brains, they work together and they made it happen. And that's congratulations for them, those who work behind this. But the safety issue, the regulatory pathway, here there's no shortcut. That this clinical trial, many of our colleagues who are listening today, they are involved in such trial. They know there is no shortcut has been adopted. The clinical trial, they follow the standard steps. The regulatory authority, when to come to look at this data and consider those evidence, there is no cutting corners. There's no, there's no shortcut. So those stringent measures to follow. Only then, if those are satisfied, the regulatory authorities will give approval. Yes, there are approvals also different steps of approval. Like today, the UK gave Pfizer for emergency use. There's a how to say this? There's not a regular pathway. There's a emergency fast track pathway. but that doesn't mean that compromise the safety. But still, we have to understand that we who don't have any experience. This safety data based on clinical trial data. Usually, we have 3, 4, 5 years long use, and then we have more information about other challenges a vaccine or efficacy a vaccine may have, and based on that, we know we can have a better decision. But for now, we have to rely on the clinical trial data.
Thank you.
Those are sufficient, but still, yes.
Thank you.
The question remains. Thank you.
Let us keep our question short. I mean, I certainly agree with you. We don't know about the long-term safety, but certainly even BioNTech today, about a couple of hours ago, they said they are continuing modifying the vaccine. Even they may produce product which could be kept in ordinary fridge. So they are promising something which may or may not happen, which is good news because what Dr. Omar looked at the chain. I will hand over to Dr. Tawfik, but let me put this question from Peter Wesley. I don't know where the location, talking about how practical in relation to Dr. Omar, excellent presentation, how practical the issues for these 80 countries which are not producing the vaccine to receive this vaccine within this year? It's a very specific question. Dr. Najim?
Hi, Prof. Yes, I'm with you. Dr. Ali, if I may ask you to unshare your screen because we're still looking at the CT scan. The issue, thank you. The main elements of this is -80 is a technology that even the best of developed countries have zero, that's zero with an O, experience of handling before. So we're talking about the areas of liquefied gas, we're talking about space agency, we're talking about genetics and genomic industry. These are the ones that usually handle things at that temperature. Most of the countries that we're talking about today, either part of ArPHA or the MENA region, will have no experience in handling these vaccines. Now, does the technology exist in terms of sourcing? Yes. So what you need is the right technology. Some of it is very expensive, very limited. You need the right people. So that means the training of these people. And third, you need the right processes. So at any one point where that vaccine comes out of the transport chain, it will have only 5 days to be given to a patient. So that's why, I mean, it's very important to always consider what are the other alternatives, and is it worth waiting for a few weeks before jumping the gun and going with the first vaccine. Just, I have one other remarks on that level. People tend to forget phase 3 trial in the science of clinical trial is not the last phase. There is phase 4, apologies. There's also phase 4 trial where more data getting collected with the first people that will get the vaccine. And also I want to comment on Dr. Ali's point. Dr. Ali, the WHO and also most of the regulatory authorities around the world do accept now a 50% efficacy rate. So out of the 100 Chinese people that you have working in the oil field, do expect 50 of them, and that will be acceptable, to do contract COVID at some point. I mean, that's what the WHO, that's what the regulatory authorities having as an 8 point. So just to make everybody aware.
Okay. Professor Khoja?
Thank you. Thank you.
Salman, really, as you said, I would like to echo what you have said. It is a great, excellent presentation. Really, we are in vital need to have such thorough information about the vaccination. As I said earlier, I have now 12 is instead of 10, 12 questions. I will start with 3. Yes, it is not me. It is the people sending me through WhatsApp. They are watching and they are very.
Well done, well done.
Yeah.
Let us start with 2. Let us start with 2.
Okay,
we
okay.
Let's hear. Come on.
Okay. Thank you, Prof. They said maybe everyone should have going to take the vaccine. And people ask a few questions and great concern about, and they get the heart of the issue of this, what we have presented right now. They would like to know, this is mRNA, is a new brand of vaccine with a new technology. Does this, what we heard from the news and from the rumors, whatever we can say, there will be a mutation of our own healthy cells. So is there a follow-up in this issue? Is this a trial on rats or whatever? Does this really happen in the past? So this is our first question. The second question is that you said it is related to what Dr. Najim said right now. This is a genetic sequencing of the portion of the virus, and it is a new technique, and it is like a gene therapy, and the data is 2 months only for such a new approaches, and which really we need for any pharmaceutical product is clinical randomized controlled trials, long-term studies. How can we depend on a short term for a mass global vaccination? So this is the 2 questions for all of you. Thank you.
Thank you. Good questions. I think the world is between a rock and hard plate. 2 choices. Which one you choose? Dr. Hasan. And I go to Dr. Omar.
Yeah. Okay. I understand that the question is about mRNA vaccine. Yes, mRNA is a new technology for vaccine production, but mRNA is nothing. It's not new thing. That's also true. But yes, we haven't. There has not been any other vaccine developed so far before this on base of this technology. The risk animal trial, of course, animal trial was done before human trial. There is a phase of animal trial. Yeah, that has been done. Mutation chance. In my limited knowledge, I can't say that happens in such situation. Of course, there are many learned professors and experts are here. They may comment on that. The risk, you can say, you're saying that very short, it needs a randomized control trial, long-term trial. Yes, that's necessary. But phase 3 trial is actually done on a huge number of populations, thousands of populations. It's done. And that's minimum requirement is fulfilled for phase 3 trial. But as Professor said, Professor Najim said that there are further requirement of data that continues beyond phase 3 trial. That's true, and we get more information. But so as of now, the recommendation will come based on available information as of today. Thank you.
Thank you.
Yeah, Omar. Yeah, carry on, Omar.
I'm just going to give very brief description of the area that you alluded to, Professor Tawfik. So in the world of genetics, there are 2 things. So there is CRISPR. The CRISPR is the technique that will go into a cell, change the DNA, and produce the desired effect. That's different from a genetically modified virus or genetically modified elements. So the mRNA basically is looking at the virus, looked at what is specific about the virus. So it says there are some nails available on the wall of the virus, and the responsibility of these nails is the specific gene inside that virus. What they did is take that gene, put it in a messenger virus, put some fat around it, and produce it as a new virus. It should be harmless from going forward. But the short answer and the direct answer, and don't let anybody else tell you about otherwise, is we don't know. And we don't know until we know. So BioNTech being in this, doing the mRNA and trialing it, same thing with the Moderna for the last 15 years. So as Hassan was saying, it's not a new thing, and they've been trying mainly to target the cancer cells and some other immunity conditions until the virus came along. The other ones that also, so no technology exists. The other one is the viral vector. Viral vector, which is the Oxford, the Janssen, and the Russian vaccine, has been trialed before. So they did produce viruses around, vaccines around Ebola, not to a great distribution. So again, back to the concern, hasn't been done on huge population. No, it has not, but it was mainly targeted at the population around the Ebola. So these are the two vaccines. Otherwise, the rest, I think it's fair to say they are old style, let's say tried and tested vaccines. I hope that answers the question and gives some.
It's a good answer. Thank you very much indeed. And very good questions from Professor Khoja and his colleagues. The messenger RNA is used, as Dr. Hassan said, is used in therapy, but never used in vaccine. Yes. So this is the first time. Again, even in therapy, there's no long history about it. I think we need to invite, we have prominent colleagues in the UAE, Mariam Matar, Dr. Matar, well known in genetic, and if she's listening, we will welcome her joining us even briefly. Another question, Professor Khoja?
Yes, thank you, Professor Salman. I am, as you know, a public health person, and really I have a concern.
We cannot hear you.
Oh, sorry, sorry.
Mike.
Sorry, Professor. As you see, as you know, that I am a public health person, and I wonder. I thought it is it is a 6 vaccine now from Dr. Hassan. It is 9 vaccines. So for me, as a decision maker at the Minister of Health or any country, and we would like to vaccinate the public, which one we should use with all of this information? You have so many information given to us. This is very good for an interested people, but for a decision maker, he has to have a yardstick. Okay, he has no time to. He has a limited resources, limited time, and pressure of the and the pandemic. So I don't know. For me as a health personnel, I feel I am a little bit confused. Which one to choose?
It's a good question. Omar, it's an excellent question. Which is logistic will be the deciding factor?
So I would based on 4 factors. Logistics is one at the end of the day. Price, again, these logistics and price will come later. But look at the efficacy, look at the safety. And it needs to be from resources that you can trust and something that you need to put your scientific into it, your scientist people into it, and let them examine it in very much details. Logistics and price will come later if you have a few choices. But sometimes you don't. Sometimes you say, the only available one for the next 6 months is one of these 2. And you might go with these 2. As you heard from Hassan, 20% only most of the countries is going to, they will get the best of that proportion from COVAX. Now you go into bilateral negotiation, they will say end of next year, please.
So can you, because we missed your sound at the beginning, can you say what are these 3 very quickly?
So 4, so first and foremost, safety. Second is the immunogenicity. Third is the logistics. And 4th is the price. Now you need to assign weight. If you don't care about the logistics, you don't care about the price, you are a country that is more leaning towards having plenty of resources around this, then safety is the most important. I would give that 50% and probably 20% for immunogenicity and 15% on price and logistics.
Yeah. I mean, when it comes to the immunity and safety, we are depending now on these solid body, which called the regulators. And we have 3 bodies in the world, which is well known, and they are very meticulous. I think Dr. Hasan and you mentioned that. The FDA, we have the UK agency, the MHRA, and indeed the European Medicine Agency. By the way, these 2, the UK and European, were one, but after the Brexit, they split into 2. So I don't think they will really license any vaccination without assurance about at least short-term safety and some evidence of immunity. But as Professor Khoja said, I mean, is 2 months or 3 months or 6 months sufficient enough to get that assurance of immunity? And Dr. Omar mentioned 50% efficacy. I mean, that's fair, but I think if we want to reach herd immunity, we have to cover at least 70% of the population with vaccine. Absolutely. I want to come back to the priority, Dr. Ali. You are in a country which is a fragile country, or described as a fragile at the present time. What do you think? Dr. Hasan mentioned priority will be the healthcare workers. In United Kingdom, we put a priority the nursing home, number 1. People in nursing home and the elderly, and then healthcare worker, and then people over the age of 80, then 70, then 60. So eventually, in the first few months, we will cover everyone over the age of 60 if they wish to receive the vaccine. Dr. Ali.
Yes. I think health worker on priority, and then the age factor and older age group. Meanwhile, there is a question. What instructions from the and for infection control, personal precautions for vaccinated patients? I mean, what instruction should be considered for infection control, for personal precaution, for vaccinated patient? Shall we talk him that everything would be safe, or should be the mask and distancing and all the odd precautions considered? This is an important question.
Oh, this is a good question. Omar?
So I think the first thing we have to remember, just around the time we are meeting today, 1 year ago, 1 person got infected, and then 1 person. We are in where we are today, where almost the whole world is in lockdown. Well, most of the world is in lockdown, and with all the consequences and the story that we all lived through. So until that arrive, I think the best vaccine that we have in our hand is the mask, the social distancing, and the washing of hands.
Yeah.
This is the best vaccine we currently have. The evidence are there. Evidence has shown, and again, the huge impact on them on reducing the transmission of infection. The second question, Dr. Ali, that you posed, yes, it might protect the person, but so far we don't know whether it will break the transmission. So I might be vaccinated, I wouldn't got a COVID, but I still might be able, or might be, carrying SARS and CoV-2 in the nasopharynx, and it's replicating there. With 1 cough, I can give it to other people who are not vaccinated. So that the audience or the judges are still out there to saying, is the vaccine going to break the transmission or only going to prevent the disease? Again, it's one of the questions that will only be answered as we go along. Most of the WHO suggestions to arrive at the herd immunity by vaccination or by infection is you need at least 70% of the population to be there, because of the nature of the virus and the nature of how people interact, and depending on the community, depending on the society, obviously.
That's very good. Well done, Omar. And there is a question from Hussam Qaddoura. I asked actually a couple of practical questions. I thought I put it to the end. Could a global vaccination lead to eradication of COVID-19? I think the answer is really, we hope so. If we reach the 70%, and with the current state of the science and art, is eradicated. As Omar said, last year we have one case. Now the whole world is actually affected by this, including the world economy. And there is a question from Mohammed Al-Khatib. If we are not sure about safety, then why do we rush for mass vaccination? It's a very good question, and I really, Dr. Mohammed and colleagues and all of you participating with us today, we have great honor to have you with us. I don't think any, as I said earlier, any licensing authority, and these are very well-known regulator in terms of medication and medical products, they wouldn't allow it to go to the public, especially we are talking about healthy population. They wouldn't allow it to go to the public unless they are 100% sure it is safe, you know. At least in the short term, we don't know what happened in the long term, number one. Number two, we are in world crisis. I mean, this pandemic must be the worst things happening in the recent history of humanity. We should celebrate the science, should celebrate the ability of scientists. They are colleagues sharing with us offices, you know, in the same university, you know. We know them from distance, you know, and these almost in 150 institutions and companies around the world. These are fantastic achievements. There is no record of vaccine produced in such a short period of time. So we must celebrate this. And we congratulate them and ourselves that there are people willing to provide something to protect us. So there is an opportunity that we are pushing that agenda of protection and changing the suffering of the world. Tawfik, I have many other questions. Do you have questions in your pocket?
Yes.
Which you want to fire?
Yeah, thank you so much. During my research...
Mike, Tawfik.
I am sorry. During my research of this subject, which is a really vital subject, I would like to bring to your attention that there was a study in USA by Gallup Poll, and they came out that the American willing to take vaccine, COVID-19 vaccine, is 58%, and they are opposition for 42%. And from what we have seen in our WhatsApp group on people who are supposed to be as a healthcare personnel, there is a lot of opposition. I receive a WhatsApp. They said, let us other people try it, and then he's a consultant and he's a professor speaking like this. So what are the strategies that WHO and you also, Dr. Najim, we should apply to our nation in order to accept the vaccination if it is proved safety and efficacy? Thank you so much.
I mean, this is a big question about vaccination acceptance and whether we are preparing the population to this eventuality. I really strongly believe the public is prepared. The public looking for a solution. The public, they have fatigue of this pandemic. Dr. Hasan, Is the WHO have a clear strategy in terms of preparing the people for the vaccine?
Yeah, thank you. The short and direct answer is transparency. You keep the data, keep the information, all the information, whatever available, the safety data, efficacy data, you make it transparent, make it accessible to public in their own language, not like scientists, experts language, by trusted people like Professor Salman and other public health leaders in the region, in your country. They explain in transparent way, in a simple way to the people, they will trust it. But if we like to overemphasize, we like to say half truth, half information, that will make people more conscious. People has source information from many sources. They can access, and when they try on by themselves, they get sometimes wrong information, and that twists their decision. So the answer is transparency, whatever available, share with people. At the same time, we have to have a national strategy for every country to handle the rumors and misconception, misbeliefs. And of course, the clinician, public health professional, they have a strong role to play here. Thank you.
Thank you. Dr. Omar, I think the more we have vaccines licensed, if we have 6 or 7 or 8 tomorrow, people will have even much more confidence. If I don't like the messenger RNA, I will use, viral vector, because it is existing, or I will use attenuated virus or something like that, Once we have this menu of choices, I mean, now we have only one in the whole world, and it happened to be in my country, in United Kingdom here, it doesn't mean that the only choice available to us. And I believe the more we have choices, the more people will have confidence. What do you think?
I tend to agree, and I agree with Hassan as well. You're absolutely right, Prof. The more choices you have, the more people are likely to take it, because you are taking the excuse at that time. I mean, the vaccine and taking vaccine and accepting vaccine will continue to be a challenge. It's been a challenge before COVID and will continue after COVID. The US, I mean, 60% is very good. I think if you arrive at 70% or 80%, that will be even better as an acceptance for that vaccine. I think that the acceptance in the US is obviously different from the acceptance in the UK, the acceptance in Europe, the acceptance in Arabia. There is an element of trust between the populace and the government and the leaders, being it scientists or politicians. And if that trust is based on transparency, as Dr. Hassan was saying, even better. And also how these countries behaved and responded during the crisis. If that trust being building up to a good level, then I would anticipate the vaccine uptake will be better. If that kind of response during the crisis was not as good or a bit hesitant, it will be very difficult for the population to accept their leaders' advice on taking it or not to take it. So I think you need to take all of that in consideration. It's a problem that we will be facing.
Yeah. Dr. Ali, as a clinician, how you would, because you see patients every day, you see healthy people suffering from other conditions, are you going to recommend this vaccine or other vaccines once they are available to your patient, and how your recommendation will actually be given? You have 60 seconds. This is the last one. I'll give it to you.
Yes. By the way, for risk group, is it optional vaccine?
For risk group, it is not mandatory.
Is it optional?
Not mandatory.
It's mandatory.
No.
It's not mandatory or mandatory?
Not mandatory. Not mandatory.
I have a comment. The problem with the vaccine is not with the type of vaccine. The problem with the uncertainty about the immune body response. For short term, yes, but for long term, We have no guarantee. That's why I think we have to continue with ABC protection measures and probably for years.
Yeah. Well, thank you very much, Dr. Ali. It's a good finish. And this is exactly in line with what Dr. Ahmed said. Face and hand and the space. We need to remember these. These are the best vaccine available to us, and we need to continue for some time to go. And we need to make sure that these are the best weapon to the virus. We are run out of time. Let me thank Sara, Hassan, Dr. Hassan, Dr. Omar, Dr. Ali, and my dearest brother, Professor Khoja, and of course my team in London, led by Chido and background colleagues. Thank you very much indeed. And we'll see you in 2 weeks' time. Having said that, there is a proposal to do something next week about surgery during COVID. I'm sure Omar would like that, but we'll put it on our website. Thank you very much indeed, and good night, good morning to everyone. Take care.
Thank you,
so much.
Well done. Well done. Thank you so much.
Thank you.